All right, let's take a look at the case. And I know I'm on an occlusion jag, and there's a reason for it. Occlusion just isn't taught very much anymore. We don't pay attention to it. And we can and we should. I'm going to show you a typical case. Why? Here's a patient who's been under periodontal care for the past 20 years. And frankly, periodontal care has been quite good, except for one portion. And by the way, he comes to us from out of town. He's moved here, and he needs to find another periodontist. He's been seeing the same periodontist for 20 years, and he just had $20,000 worth of LNAP done, he says, a couple of years ago. I didn't verify with other periodontists. It wasn't necessary. But he saw somebody in our area who said you need all your teeth out and have implants placed. And so now he's here for a second opinion, so he wants, as he says, an honest second opinion. Unfortunately, this doesn't show up as well as I'd like it to. You'll get an idea of the thumbnails, and you'll see that. We'll take a look at the CT scan. But what you'll see is there's a great deal of bone loss on tooth number 2, on the distal number 3, and you see the apical lucency on tooth number 4. Same thing is going on number 14 and 15, and there's some mobility on tooth number 15. What I'm going to do is to drag the cursor, and we'll just look at tooth number 2, and we'll look at tooth number 31. So you see the deep lingual defect here, and tooth number 2, you can get an appreciation as to how little bone support there is for that tooth. Let's go to number 3 and number 30. Okay, that's better, isn't it? Now, there is a distal pocket in tooth number 3. It's a pocket of about 5 millimeters, and I'm feeling a little bit of calculus, but it's actually not bad. And a pocket of 4 millimeters on the facial. Yeah, you can see the erosion here. We go to number 4, and then we see the apical lucency. By the way, you saw the apical lucency anyway, and I want to, apical lucencies just show up better in CT scans, as you know. And that's why a CT scan is taken on every single patient who walks into the office. Every single one. Unless it's a teenager or something like that. Every single one. But I want to give you an idea as to what's going on with the occlusion. Let's take a look. And by the way, CT scans are always taken in occlusion. Yes, I know they tell you not to. Take your CT scans in occlusion. You want to see what teeth are meeting and what teeth aren't. Oh, I know surgical guides, some people say you need to separate them. You really don't. You really don't. It's just a matter of knowing how to harness the software. But if your technicians say, or your laboratory says you need to, take a second CT scan on the few people that you're going to use where they're going to have to construct a surgical guide. Occlusion tells a big part of the story. And you'll see that a lot of these anterior teeth are not in occlusion. It's worse than that, though. Nearly no teeth are in occlusion. The only teeth that are in occlusion are teeth numbers 2, 3, 15. That's it. That's it. That's all that's in contact. And there we go back to tooth number 15, and you can see the amount of bone loss on that tooth is interesting. Tooth number 18 does not have as much bone loss, but still there's a funneling defect there. Okay. So, is this trauma from occlusion? Of course it is. Now, there is severe periodontitis, but if the patient's only banging on his second molars, how can those second molars respond to any periodontal treatment whatsoever? So what are we doing with this patient? We're going to take we're doing study models. We will look at those study models. We can articulate them through the software. These are scanned. We're not taking direct impressions. And we can get an appreciation as to what we can do to get these teeth into contact before we address pockets or decide on extractions. Imagine the primary contacts are on the second molars only, one first molar, but second molar is where most of the contact is. What happens if he loses the teeth? What teeth will be in contact then? So the goal here is going to be to get as many teeth in contact as possible through occlusal adjustment, maybe orthodontics, but he won't go for that. And it's likely we can do an occlusal grind and take the stress off of the second molars and maybe keep the second molars a little bit longer. We don't know that. And the rest of the teeth, other than the first molars, which have some a little bit of pocketing there and a little bit of calculus, there's nothing else that needs to be done. So shim stock is a part of our examination. I encourage you to be part of your examination. It's going to be one of those things where the patient is going to say, nobody's ever done that before. It adds thoroughness to the examination, and it'll give you a much better idea as to how occlusion may be participating in the patient's overall dental or periodontal problem. Thanks.